So these are the topics under the introduction: history and principle of community-oriented primary healthcare, core principle of community-oriented primary healthcare, key concept of public health, social determinants of public health in community context. Under the subheading, we have classification of social determinants of health and social gradient in health. These content is what we have in our book. So that's what I'm working on. Now, what is introduction? Community-oriented primary health care is more than just medical strategy. It's more than doctor and patient. It's a philosophy that shifts from the focus of treating the individual isolation to treating the individual as a member of a specific community. What am I saying by that? It's not just treating an individual, that's me and doctor. And it's not just it's treating that person based on the community, what is happening around the community, what's happening around that person as a whole. I've been saying community. What is community? Community is a group of people living in a same place or having a particular characteristics in common. We can say, like, for example, now I'm living in Port Harcourt. I can say my community now is Ozoba. In that Ozoba, these people here, they are suffering from light issue. Maybe they have a good housing. I can't compare myself that I'm living in Ozoba to somebody that is living in GRE in Port Harcourt. So that is what community-oriented primary healthcare seems to identify. It is saying that people living in a better place have a better chances of medical healthcare than people living outside, like living in a rural area. But primary healthcare, now let me just separate community and primary healthcare. Primary healthcare simply means a care that is affordable to me, or to my own understanding, where we still go down to what WHO says about primary healthcare. That is affordable both to the rich, to the poor, and everybody. If it's not affordable to the community, it's not a primary healthcare. So think of, now let me go down. Think of it as a bridge between clinical medicine, the person in front of you, and public health, the population at large. So it's in between. Public health is discussing public health discuss in population at large. Clinical health medicine is discussing me and you. I'm the doctor, you are the patient. But community-oriented primary healthcare now is in between. It's neither there or here. It's just standing here. That's in the middle. So let's go. Community-oriented primary care emerged as an innovation solution to address health inequality in undeserved community. In the sense that this community-oriented primary healthcare, how did it come about? It came about there are some group of people back then. These people are not receiving good treatment, which we will talk in the history. So that is where it came down to racism in South Africa. That's where this community-oriented healthcare emerged from. By focusing on this community as the unit of care, emphasizing prevention, and incorporating epidemiology data into practice, community-oriented primary care offers a comprehensive framework of primary healthcare reform. That is what I was saying before. It's all about primary healthcare, that it's accessible for everybody. Me, the poor, the rich, the middle class, everybody. It's not just for one person alone. And it is addressed by how the environment is. If this place is a rich area now, that means expect the healthcare in that place to be very strong. And it's a very, very affordable. That is one thing. Or everybody in that area must be able to afford it. That is one of the things. They must be able to afford it. Community-oriented primary healthcare is vital, enduring approach that champions equality, community engagement, and evidence-based practice by treating the community as both a patient and partner, offering a comprehensive model for inclusive and sustainable healthcare transformation. What am I saying? In this place now, the patient and the patient is the partner of the people working in a community-oriented primary health care. What do I mean by this? The patient will be engaged. Example now, let's just say immunization, vaccine. This there will be an engaging, that there's a discussion. They will make sure that these people participate fully in the activity going on. Are you hearing me?
Yes, we can.
Hello?
We can hear you.
Yes. So patient must participate. Once patient is not participating, community-oriented primary health care has not been carried out. Patient must participate. They must be involved one way or the other. The people championing this thing, we have to educate the patients, and even if the patient is sick or not sick, they are also involved in this community primary health care. Now, let's go down to the history of community-oriented primary health care. The roots of community primary health care are deeply tied to social justice and realization that medicine is ineffective if the patient returns to the environment that made them sick. First of all, community-oriented primary health care started in South Africa. How did it start? There was racism, according to the history. And these people, they are black, and they cannot come to this hospital. They cannot do this one. They cannot do that one. So Sydney and Emilia Clark now came together and said, okay, since these people are making this thing difficult for this rural area, so they brought up the idea that let's go into the rural area and integrate with these people and talk to them and make this health, like bring health to them, communicating with them, even using their language. I can maybe, to me, or I believe this Sydney and Emilia Clark is not a South African. So that's what I didn't really find out. But they went into the community to make sure that those people understand them. They did not judge them based on that era where there is racism. So the concept was pioneered by Sydney and Emily Clark in South Africa. They integrated clinical care with environmental health and social services. They said that health should not just stop in biomedical aspects. It should be biomedical and social. It should join together. They brought a service, social service, and this thing, environment, like a gathering where there is discussion, where maybe there was even food there. I'm just imagining, that's what I thought. Maybe they will even provide food for them. Providing the infant mortality could be disastrous, reducing by addressing local nutrition and sanitation alongside vaccine. They brought food. Okay, on a day this area is not good. They brought clean food, clean water, and taught this community about vaccination. So after doing this thing in South Africa, there was a move. There were some other racist people were now disturbing them. Then Sydney, they traveled to United States. According to the history, he had to now move because there was small katakata, according to them. So he moved to where he now made a bold declaration. There were now community that was able to hear him. As you can see, there were people that was able to listen, people that can lend hand. That was when this Alma Mater declaration came, because he left South Africa and moved down to United States. So this Alma Mater declaration, that is what brought the first community-oriented primary health care in 1978. So sorry. Oh, no. In 1978. So they now form a primary health care center which attend to everybody. What did they name it? Health for all. Community primary oriented healthcare provide the practical framework for the global ambition. Now, in this place now, when they brought about this alma mater declaration, they said health is not just for the rich, health is not just for the middle people, health is for everybody. Health is for all, not just for one person. That is when this community-oriented primary healthcare now came fully, like in the boss. So sorry to use that word, but that's what I'm using, remembering it. So, in all, the most important thing is to know that Sydney and Emilia Clarke are the pioneers of communities. In 1978, Sydney moved to United States, where he shared his knowledge, and they came to say health is for everybody, it's not just for one person. And this alma mater declaration came. So that is just the history, the roots. So let's move forward. Core principle of community-oriented primary health care. Now, this is where it is. You define population already. Community, that is group of people. So if group of people, you have to define them. You have to know how many are there. If you are working with Asokoro, you have to know in Asokoro, which side of Asokoro am I using? Is it phase 1 or phase 2? Then when you define the population, you say, okay, this phase 1 I'm using, how many are they? You gather them together. Unlike a standard clinic that through the door. Community primary oriented care identify a specific denominator, a neighbor, a school district, a workplace. The goal is to be responsible for everyone in that group. Even those that are not sick, you sick, sick, they will count you join. That is just the truth. Giving I'm saying, but community involvement, I said everybody must participate. You sick, you know sick, you will have to participate, because health isn't something done to the community. It is something, health isn't something done to the community, it's something done with them. Excuse me. So if you are healthy, the community workers will have to teach you on how to, maybe if I'm a community worker now, for example, sorry, let me deviate a little, and I am into this community primary health care, I'll come out, okay, you are from this place, and I'm working with this place. I don't know this environment. This is what and what. I will have to educate some group of people that will assist me. You understand? And these same people now will be the one working with me to make sure that this community, this primary health care is carried out successfully without any glitch. Community members participate in identifying health priorities. Yes, they are the one that will tell me in this area don't have water in this
Is it my network or can we hear her
the road is
clearly?
bad, dusty areas, so they are the one that will identify what are the health issues involved. How do then give me some other history background as so sorry. Chidima, are you hearing me? Where is my
Yes, yes. But it
okay.
started breaking at a point. I didn't know if it was my network or yours, but go ahead, please.
Okay. So the next one is integrated service. Integrated service. So what is integrated service? This is to my own to this thing. Integrated service refers to coordination and combination of multiple previous separated services all coming together to make sure that this community primary health care work. What am I saying? Transportation will come, services will come, health services will come, government services will come, police services will come, so many services, even if it's engineering services, there is a time engineering, maybe if they are seeking for light, they will come together to make sure that community-oriented primary health care works. They will break down the wall between different type of care, thereby promoting destiny. Come and carry this child. So sorry. Please, I'm sorry for the this thing. Carry her. Promote, thereby making sure that there is promotive health education and nutrition. So sorry. Preventive, immunization and screening. This thereby curative. Then doctors, there will be doctors, there will be nurses to cure for treat the acute one, chronic disease. There will be prevention. Those community health workers will be there, attendants will be there. Then rehabilitation. Those in psychiatry, they will be there to help to make sure that everybody, and there will be a good result. You hearing me? Hello?
Yes, please, we can hear you. Go ahead. We can hear you.
Okay. So use of epidemiology. This is the science part of the model. This is even the core part. If this one is not involved, that means the whole charade that we have been doing, science part of the model. Practitioners use that shot, you use that. So use of epidemiology is very, very crucial in community primary oriented healthcare. Example, if a clinic sees 10 kids with asthma in a week, a standard doctor treats the 10 kids. Otilo. Nothing concerns that doctor again with any other person that is sick. As far as these 10 people don't come, that is the people he will treat. But a community primary oriented healthcare practitioner will ask, why are these people sick? Are there still people remaining in that place? What is causing this problem? How do we remedy this situation? That is what the only thing the practitioner will be after. Because if they don't remedy the situation, after these 10 people, another 10 people will soon come, or more than that. Interdisciplinary and team. Different departments, different what do you call them? different profession will come together to make sure that this thing will work. Based approach, employ to collaborate to deliver holistic care, address to deliver holistic, in fact, ongoing monitoring and evaluation, like the example I gave. Let me go back.
Amaka, your network is bad.
If the kids, a clinic see 10 kids with asthma.
Hello, Chiamaka. Okay.
So now, I was giving an example. I don't even know where I was again. Based approach, okay. Let me start. Ongoing monitoring and evaluation. Here, this is where I was giving an example that if is a other aspect, after treating that 10 patient, the patient did no more. But as a community-oriented personnel worker, you will go back and evaluate the situation. You will monitor, you will check and observe and say, this thing has been happening. After you have even given your conclusion, you won't just stop there. After like 2 months or 3 months, you go back there. Is this the solution that you gave? Has this produced results, or there's still glitches in that place? This is the asthma still happening? Is the people still suffering from the catarrh or cold? You keep evaluating, and the evaluation must be documented so that another person that wants to go to check that place can also make use of your work to check if this work he or she is carrying out is also the same thing, or just it must be scientifically documented. That is what I'm saying here. Now, challenges of community primary health care: weak health infrastructure. Because why I said so? One, because of one, this health most times is pioneered by the government, government to make sure that every area has this thing. Where that there is a poor example, a local environment, there will not be enough equipment there. There will not be enough health personnel, trainers. If you reach there, you may see only one doctor, only one nurse, 2 practitioners. Before you know, the place just weak infrastructure. The building itself, you will see. Maybe another thing is that one building, if that area is having 1,000 patients or 1,000 communities, is only 1,000. One building will not be offering 1,000 people. Insufficient training in interdisciplinary collaboration. That is one of another challenge, in the sense that there is no enough fund, or there is no enough opportunity to train other people to join this community-oriented primary health care. Political resistance, I've said it. Politics affect this thing well, because that is where politics, part A will say vote for me. If they did not vote for part A and part A finally win, he may decide not to assist the community oriented primary health care. The primary health care in that community, the health care will say, make I leave them, make them suffer small. Funding limitation is still boiled down to government, all of which necessity substance culture are instituted shift away from a pure biomedical model. This thing, what am I saying at this thing is that community-oriented primary healthcare have shifted from just doctor and patient down to social biomedical model. Now, we are done with that. Let's go to social determinants of health. When we talk about health, we often think about doctors and hospitals, but in a community context, health is actually shaped far by the zip code than the genetic code. Social determinants of health are the conditions in the environment where people born, live, learn, work, play, and age. They account for all 30 to 55 of health outcome, often more than medical care or lifestyle choices alone. What am I saying? The environment you live determine your health. In fact, it gives 30 to 55% how healthy you will be, how okay certified you will be. That is this thing. Unlike the medical, your genetic code as income, so it's roughly 2025, I guess. I don't know. I'm not a doctor. Let me not say something. I didn't really read it, but that is from one of the YouTube video I get. That is what but it's not confirmed. YouTube is not really confirmed. Dr. Chidima, you put light to that. Definition of social determinant of health. WHO definition of social determinant of health. They are the non-medical factors that influence health outcome. They are the non-medical factors that influence health outcome. They are the condition in which people are born, grow, work, live, age, and the wider set of force and systems shaping the condition of our daily life. What am I saying? Where you are born can determine if you are going to be healthy or not. If you are born in the slum, so to say, if you will not be that strong. And let me just say, how am I going to put it? If you are born in a way there is no clean environment, clean water, you will be falling sick every day. Your growth may be stunted growth. Now, if okay, fine and good, you have decided to leave that environment and now pursue another environment, the work you do also affects. People that work with chemicals, for example, have a tendency of developing cancer, lung cancer or any other cancer, because chemicals are very harmful to the health without proper prevention. Now, where you live also has a way of, if you are living in one room, no ventilation, and somebody living in duplex with enough AC, the skin, when the person come outside, the skin of that person and you, my dear, is not the same thing. And in fact, you age higher than that person living and doing exercise. That has another thing again is somebody that went to school and somebody that did not go to school. Somebody that went to school and said, okay, and have this knowledge that I would exercise is good for the body. And the other person now that does not do exercise, there's a two big difference. Think of it this way. If your body is a car, medical care is the mechanic, but social determinant of health is the quality of the road you drive on, the fuel you can afford, and the weather condition you face. Imagine the mechanic don't do in work. Now you carry the car, come pass for road where no good, jaga, how it could be. Then on top of that, somebody that has to buy 50 liters put inside and you will buy 5 liters, your own will quench for road. That's just it. Now, classification of social determinant, structural determinant and intermediate determinant. Structural determinants, these are broader society forces that shape how resources and opportunity are distributed. Sorry, excuse me. Governance and policy framework. This one is just talking about the broader this thing, what they call it, how these social determinants affect us. Government, that is the government and the policy framework, it affects our health. In the sense that, example now, let me use an office for example. If you're working in an organization where the policy is you must clock out by 8, and somebody that clocks out by 4, the governance is not the same. That person that clocks out by 4 will go home and rest. You that have to wait till 8, when you go home, you are exhausted. First of all, traffic will hold you for road. So you see that it will affect your health. Income equality and poverty. If you are receiving somebody that is receiving 50,000, somebody that is receiving 500K, their lifetime is not the same. Discrimination based on race, gender, and disability. That one also follow. There is a place now, a woman will go, they will say, Madam, stand, no talk. You understand? Racism also affects structural determinant. Education system and labor market. Somebody that is educated will know how to carry him or herself. Unlike somebody that not go to school, anything goes. But some of the people when they go to school don't wise now. So intermediate determinant. These ones are the one that you yourself, the people themselves are the one. That's the one. This one is yourself. Waiting they happen to you, not other people what they impose on you. This one is what you are doing to yourself. House quality, the house you are living, the food you are eating, the social support and the stress level. Do you have social support? Do you have time to enjoy yourself? Do you have time to socialize? Is the stress level high? Do you have time to at least distress? Health relation behavior. Are you checking your health? Or as they go every day, bam, you don't do over. Thank you, Jesus. Access to and quality of health service together. Hello, are we there? Are you hearing me?
Perfectly, we can hear you. Please go ahead. Yes, yes.
Okay. Now, we'll move down to social gradient in health. This one, I not to understand them, but I will just rush and. Maybe you go help me. Social gradient in health, in terms of, is a term used to describe the phenomenon where people who are less advantaged in terms of social economic position have worse health than those who are more advantaged. What are they saying? This thing is just where you live determine how healthy you will become. It's not like if you are very rich, that means this is step by step. Somebody that is very rich will have a very good health. Somebody that is a little bit less richer will still have a good health, but it's just like they are trying to, is a calculation, trying to calculate based on your social area where you live, your finances, your environment matters a lot. So somebody that is very poor, we have a poor background health, this thing is just small. It's not just from the poor to the rich. Now, this one is a calculation. Okay, yes, so somebody that is living in GRA we eat better than somebody is living in Ajib. Then somebody is living in Ajib is far better than somebody that is living in Ozoba. Then somebody that is living in Zoba is far better than somebody that is living in Alo. I'm just using Port Harcourt, that's where I'm staying, for example. These are places, they are just saying they are calculating it based on hierarchy. Now, it's not just there will be a middle. It's okay, rich and very poor. No, it's a continuous step. Small. You will be recording it. You'll be recording it as a community-oriented personnel. You will have to record it to see the gap difference and to see how you can be able to adjust to close everything. It is not just a gap between the very rich and the very poor. Instead, it is a continuous step-by-step relationship that runs from the top to the bottom of the society. Essentially, the higher your social position, the better your health is likely to be. Assessing a social determinant of health. Assessing a social determinant of health at a community level is the process of moving beyond doctor's office to understand the cause of the cause. What am I saying? Is leaving your comfort zone as a doctor, leaving your comfort zone as a medical practitioner, leaving your comfort zone as a community-oriented personnel, to going from house to house, learning what are the barriers that is making these people health deteriorate. Then how do I fix it? How do I, like, taking data, taking record? It involves looking at the environment where the people live, learn, and age, to identify their barrier and to work on them to get an holistic health. Now, all through the community diagnose, integrate both. Okay, what I'm saying here is there are two ways for you to get that data. There are very two ways: quantitative data and qualitative data. Now, what is quantitative data? Is an information that can be measured, count, and expressed numerically. Quantitative data are numerical. You can count them, you can measure them. While qualitative, these are non-numerical information that cannot be counted. It's an emotion, their well-being, how are they feeling, how are they doing, is the body hot, and all that. Then let me read through. Quantitative data collected through household survey, health information system and sensors, they can be measured. Income level, how is this person finances contributing to his or her health? Educational attainment, this person that is learning, how is he helping him or her to live a well-defined health life? Unemployment rate, yes, like if you are using Ogbogoro, for example, sorry, I'm using my Port Harcourt, you can use your own state. Now, the unemployment in this place, how is it affecting the health of the people living in that place? People that are working, how are they, the money that they are receiving? Because somebody that is working in this Bogoro now, maybe what they are going to be paying the person now is maybe 100K a month. Is that 100K enough for her to live a good, healthy life? Then the one that does not have the that doesn't have the job set, how is the person managing? Nutrition and disease prevalence. Now, this quantitative now, we calculate the nutrition, we calculate the disease prevalence, we calculate unemployment rate, is how to, we calculate educational attainance, we calculate income level. This is what this quantitative data does. This is what it will calculate for you. But qualitative data will gather community voice and lived experience through. That means it will gather their feeling. What did they how did they feel? Focus group and key informant interview. You will not be interviewing, okay, madam, you are living in GRA. What is now the health factor? What is happening? What are your disabilities? What are your abilities? Or how do we, then you write to go and say, okay, these are the disabilities, these are what we're going to do them. Then now you go back again, then you move to the next level. You are living in Ajib. What is your disability as an ability? Then mapping and ruling the appraisers. Then, okay, now you want to work, you now map out this area. Okay, I will use this area, for example. I will work on this area to this area. Cultural norms and local definition of it. You also know their culture, because if you are going to work in an environment, they say when you go to the room, behave like a room. You have to study it. Qualitative data will help you to study their distance, so that there are some places now, and they'll say you don't come out on a K market day, you now go and come out. Now you sabi. So that ends my lecture. So in conclusion, community is a group of people living in the same place and having a particular characteristics in common. Primary health care is essentially the front door of the health system. If no primary care, health system, I'm not sure say it will move, it will be there will be any improvement. It's based on the idea that health is a human right and should be accessible affordable, and focus on the whole person rather than just treating specific diseases. Any healthcare that cannot be affordable is not an healthcare. It must be accessible. It must not, in fact, make it no far from the, like in community primary healthcare must be in the center of the community. If it's far, in don't come up for primary healthcare, in don't turn to another thing, maybe private sector. It must focus on individual, that community. In fact, the way they will build the place, it should just be free for everybody in that area, like accessible, and able to treat diseases, specific diseases that is worrying. If eventually now these people a lot, let that community primary health care give them that treatment. So in all, community primary health care is treating the community as a patient, not just one person. Thank you very much. I'm done.
Thank
Chidima,
you. This was
please,
awesome.
your mic.
Thank you. Thank you. They are clapping. I don't know if you can see the clapping emojis. Thank you so much. This was awesome.
Thank
Like you
you.
practically came to
Thank
lecture
you.
us. You even prepared a whole slide. I mean, this is you raised the bar for us. Even I've never prepared
For
slide
we.
for teaching like this. Thank you so much. You did awesome.
Thank you. Thank
Yeah,
you.
I don't
Please,
think
if
you
you,
can see the uploads, but they are clapping and they are saying thank you in the comment
thank you.
section.
Thank you. Thank you.
Yeah. All
So,
right, my people. So, um, this evening we've already listened to Chiamaka. She did awesome. So I'm thinking let's just answer a couple of objective questions, right?
yes.
Our just to, make it sink. Our, what is it called? The exam for this course is essay. So what we are answering is not necessarily essay, but if we have I'm coming. If we have objective questions, at least it will help us test our knowledge and we'll be able to know what we understand and what we don't. So for those who didn't join early, the summary of this course, community-oriented primary care, there are different levels of healthcare. There's primary, secondary, and tertiary. So primary healthcare is the one closest to the people. Primary healthcare is supposed to be the first point of contact. So all those community clinics, they're supposed to be the first point of contact between health practitioners and the people. And then the idea of it being community oriented, it came from, like she mentioned, from South Africa, Sydney and Emily Clark, where they were seeing patients, they're in the hospital and they are seeing patients. You see 5 cases of common cold or cases of diarrhea today. Tomorrow, you may even see those same children coming again. They've developed the same thing. So they felt instead of us just sitting down here and, treating these people for this same thing, how about we go into the community to find the source, to know what is actually happening? If you are a Christian, it's like that thing they say that you don't sit in church and wait for the sinners to find you. You don't sit in church and just balance and wait for the sinners to come to church and meet you in church. You should go out into the world. You should go and look for them. You should go for evangelism. Go into the community. Go and look for the sinners yourself. So that's what community-oriented care is like. You say, no, we can't sit back in the hospital. We need to integrate with the community because there's something called the iceberg phenomenon, which I will just show us a picture of. The iceberg phenomenon, what this phenomenon is saying is that the people that come to us in the hospital, the cases we see in the hospital, if you look at this picture here, you would see that you can see there's a small iceberg here. So if a ship is coming and the sailors they don't have they are naive and they don't understand the way things work in the ocean, they may think it's not so big. But then there's a huge mass of ice underneath it. So what we see in the hospitals, they are like the tip of the iceberg. That's the iceberg phenomenon. What we see in the hospitals, they are the tip of the iceberg. So if you treat 5 people today, there are like 20 more people that have that same thing you are treating people for in the hospital. There are 20 more people that have it there in the community. So why don't you go into the community and try to teach them how to improve their environment, how to improve their sanitation, how to, identify, okay, oh, it's like this person is beginning to have fever. This is what we should do when a child is having fever. Let's expose the child's body so that the temperature can come down. So you go into the community and teach them all those things. So that's what this community-oriented primary care is all about. Okay, so it started in South Africa and then it moved to Israel. It also got to the United States, and now there are a couple of countries that have adopted this community-oriented primary care. Okay, so Chamaka has done a very good job. So what we are going to do this evening for the next couple hours is to answer questions. Let me see. Why can't I see my... Oh, you couldn't see the picture. Could the rest of us see it? Did we even see the slide I was showing? This thing I showed, the questions I was displaying. Ewo, Ewo. Oh, I have to share my screen. I'm sorry. I have to share my screen. I have to share my screen. Okay, so I guess we can see it now, right? Nobody is responding in the chat. Please, can we see my... Okay, yes. All right. So let me just show the iceberg that I was showing us earlier that we didn't see. So this is it. This is it, basically, the iceberg phenomenon, okay? It's just saying that the number of persons that come to us in the hospital, they are very little compared to what is happening in the community. And so it's not wise for us to just sit down there and say, okay, we want to see, we're not making impact if we just sit in the hospital and say, we're seeing this, you see 5 patients that have this, you see this. Of course, the hospitals may be full. You'll be seeing 100 people in the hospital that have maybe common cold or something. But the number of people that have it in the community that will not come to the hospital, there are a lot. So that's what this iceberg phenomena is saying. Essentially saying we should integrate our clinical practice with the community. Okay, so let's go to answer questions. I want to unmute us because I need us to be able to talk. Okay, so we are unmuted. So if you want to talk, you can mute yourself, but if you want to talk, you can just let us know and you talk. So we have questions here, okay? We're just going to answer them quickly. They are from the material. I basically used Notebook LM to generate these questions. So the first one, the term holistic is derived from the Greek word holos, which means what? Look at the options. Whole, good, okay? Which orientation represents a shift towards focusing on factors that support health and well-being rather than just the disease? Look at the options. Pathogenic,
B.
Orientation.
B. Salutogenic.
Salutogenic, okay? Then number 3, the 1948 WHO definition of health is criticized for what? What is the criticism? A, ignoring social well-being. B, focusing too much on spiritual health. C, setting an unattainable standard of complete well-being. D, being too narrow in its physical scope. C, correct. C.
Setting an unattainable standard of complete well-being.
Yes. Okay, so let's go to number 4. In the context of holistic health, integration refers to what? A, treating parts of the body as separate system. B, how dimensions of health interact and influence one another. C, standardizing healthcare for all individuals. D, focusing solely on clinical interventions. What's the answer?
Interacting and influencing one another. B. B.
Okay, option B. All right, number 5. Which model conceptualizes health and illness as opposite ends of a spectrum? A, the biomedical
B.
model. B, the health illness continuum. C, the biopsychosocial model. D, the salutogenic
B.
model. Hmm?
Health illness continuum.
B. I don't know
Okay.
this one.
Okay, option B. Okay, somebody said they don't know it. The biomedical model, please, somebody, there's a dog barking at your end. You can mute when you want to talk, you're on mute. The biomedical model, basically, it just looks at the person as a function of the disease they have. So is the person okay or not? What's the illness they have? That's biomedical model in short. The health illness continuum is basically saying that there's a spectrum and it spans from health to illness. And at different points in time, we're at different position in this spectrum. So it's a continuum. Today you can be 100% well. Tomorrow you are 80% well. Next tomorrow is 70. So it's a spectrum. That's what it's saying. Then C is the biopsychosocial model, where it's an expansion of the biomedical model, where it's saying beyond just looking at the illness, let's also look at the psychological factors. Let's look at the social factors that affect the individual. Then the salutogenic model. There's somebody, please, you can turn off your what is it called? You can turn off your microphone. The salutogenic model, it moves away from just discussing disease to talking about what are the factors that can support health, what are the factors that can support health and well-being. I'll be forced to mute us because somebody is not muting themselves.
Jennifer.
Okay. So the next one, let me see, all these other questions, we can answer them ourselves. Let's go to the next. These ones, we can answer these ones later on. Okay, so dimensions of health. Biological functioning as a component of physical health refers to what? A, the ability to run a marathon. B, the proper operation of the body systems and processes. C, one's spiritual belief. D, the quality of one's social network. What's the answer? Just unmute and answer.
The proper operation of the body system and processes.
Okay. Okay, so which system is responsible for transporting oxygen and nutrients while removing waste products? This was in the material too. Which system transports oxygen and removes waste products? Respiratory, cardiovascular, endocrine, nervous? Is the respiratory system.
Respiratory system.
Perfect. Okay. So let me move and see. Let's go to other.
Is all these questions in our slide?
No. But it was generated from the things in our slide, in our material, the comprehensive note. Okay, so the earliest systematic approaches to health and the environment were developed by what? By which people?
The World Health Organization. Yes. Is it? Yeah, WHO. Hello?
We all agree?
It's confusing.
No, the word earliest. The word earliest.
Systematic.
Systematic.
Mm-hmm.
Systematic. Okay. It's a market.
W-
It's WHO.
The Greeks. The
Bring
Greeks.
rag,
The
please.
Greeks, the Greeks, the Greeks, the
Okay,
Greeks.
we'll go home and go and look for the answer in our textbook.
It's the
Hippocrates'
Greeks.
Where are
treatise
we going to put
on
the answer?
herbs,
Help
water,
us now,
and
guys.
places is considered the first treatise on what?
Hmm?
Hippocrates wrote a treatise on air, waters, and places. It's considered the first treatise on what?
Environmental health.
Yes, environmental health. Okay.
Environmental health.
Archaeological evidence from the ancient Athens reveals sophisticated infrastructure for what?
Telemedicine.
Mbanune.
Sorry,
Drainage
B
system and public
drainage system and
latrines.
public
Drainage
latrines.
system and public latrines. Correct.
We say
The Roman
Banune.
Aqua Claudia was an example of what? Number
Sorry, what was the
44.
question?
System.
Number 44.
See?
Aqueduct system.
Hello.
Aqueduct system.
Yes, aqueduct system providing clean drinking water. Okay. The Cloaca Maxima in Rome was revolutionary what? What was it? The Cloaca
Sewage.
Maxima in Rome.
Sewage.
Yes, it was sewage.
The sewage
Sewage.
system.
I still remember. Oh, thank God.
Sure you know we can hear you.
Ew.
Person thanking God. The Romans established valetudinaria, which were what?
Nemo.
Okay,
Public
assignment to everybody.
libraries.
Make we go find wetin be valetudinaria. Ancient Egyptian medical knowledge
Drainage
was
pipes. They were drainage
documented.
pipes.
You said what?
Drainage pipes.
That person went
Okay.
on that
Are you sure of the
knowledge.
answer? Because I'm not sure of it.
I'm helping the person to echo it. He said drainage pipes.
Okay. Ancient Egyptian medical knowledge was documented in texts like what?
I mean, really, you.
What you mean?
Okay, assignment for us again.
It's my
So I'm going
second
to send
thing.
this. There are plenty assignments. So let's go and study our material. Okay. So let's move to another one that I think we may be able to answer. So number 55. During the Renaissance, the city of Florence appointed officially the sanità, who were what? What were they? From the names. I think they were health magistrates responsible for enforcing regulations.
Please, can we get the question material? The whole question material, please.
I will think of it. Yes, I'm going to send it. I will send it. The Industrial Revolution led to severe public health challenges, primarily due to what?
Huh?
Industrial Revolution. There was rapid urbanization, overcrowding, and unsanitary conditions because many people were moving to the city. That was what happened there. So it's option B. Okay. The Great Stink of 1858 in London was caused by what?
Garbage piled up.
You said? Okay, no. It was not garbage pile up. It was the Thames. It became an open sewer. So I think so. But we'll confirm it. Now I'm not confused whether it's garbage pile up. I think it was the Thames becoming an open sewer, that the place became so smelly that they couldn't hold their parliamentary meetings. Okay. Edwin Chadwick's 1842 report argued that disease and death rates we're stopping soon. Disease and death rates were directly related to what?
Lack of what?
Environmental conditions. That should be sanitation and stuff like that.
Yes, option B. Okay.
Yeah.
Okay, the Public Health Act of 1848 in England was landmark because it established what?
The first mandatory.
Continue.
The first mandatory exercise law.
I think it's A actually. The
The
first
first
national
national,
public health infrastructure.
yeah,
Yeah. Okay, so
should
number
be
60, Dr. John Snow is famous for his investigation of cholera transmission outbreak in where?
in Paris.
No.
Harry.
Was it Paris? Was it not
Away.
London? Was it not Broad Street
London.
in London?
That's Manchester.
Cholera, Broad Street, London, no. No be
Now
Paris,
London.
oh.
Okay.
I'm on a wow.
That person wey dey say na wa shey you know say we dey hear you. Okay. Germ theory and the rise of epidemiology. So germ theory shifted the focus of disease causation away from what? What was the prevailing theory before germ theory came into play? Is
Hand
option
washing.
B, miasma, bad air. As at then, they were saying bad air was the cause of disease.
Was
So
the cause
germ
of
theory came.
yeah. Remember that one?
So it moved us away from that. Louis Pasteur's work provided crucial evidence for germ theory through his studies of what? What did Louis Pasteur study?
Fermentation and pasteurization.
Yes, that was what he studied, and that was what he talked about. And he also did the work on microorganisms, and he also contributed to the germ theory. Okay, number 63. I think people are responding in the chat box. Sorry, my guys. Okay, nice one. We're responding in the chat. Sorry. Okay, so number 63, whose postulates provided criteria for establishing causal relationship between microorganisms and disease? Somebody, once you hear
Robert
postulate,
Koch.
there's a name. Yeah, Koch. Robert Koch. There's a Koch postulate. He provided the criteria for establishing causal relationship between microorganisms and disease. So we can go and read up this is postulate later on. Okay. Joseph Lister introduced antiseptic surgical techniques using what? Another assignment.
Penicillin.
Eh? No, it
Excuse me.
was not the one that introduced penicillin. So this is another assignment.
Joseph Lister.
No, it was not penicillin.
Okay.
Yeah. John Snow's systematic mapping of cholera cases identified what as the source of infection? We just said it now.
Airborne,
No.
Pollution from a nearby factory.
airborne from nearby factory.
No, now.
Contaminated.
No,
No.
John Snow, cholera. Shey, it's not factory, it's air pollution. Now, air pollution will not cause cholera.
Okay, the Broad Street pump.
Yes, let's not forget it too. Once you hear John Snow,
Okay.
cholera,
Water.
remember the Broad Street
Bad water.
pump in London.
Pump.
Florence
Okay.
Nightingale's statistical work during the Crimean War used what to advocate for better sanitary conditions? What did she use?
All right. Rules. Just microscopic slice.
I don't think
No.
so. I think it's
Just
option
text.
B.
It's rose diaphragms. Rose diaphragms.
Good. I think that's the answer. Okay, so the development of vital statistics system allowed countries to maintain records of what?
Development vital statistics allow record of individual
Right.
dietary
And
needs.
disease cases.
No, once we have vital statistics, think of births, deaths, births and
Okay.
deaths. Births, deaths, maybe sometimes they include marriage and some other
Yeah,
things. But births and deaths, once we hear vital statistics, births, deaths. Okay?
okay.
All right. Edward Jenner developed the smallpox vaccine in 1796, but understanding of what remained limited at that time.
The existence of cows, immunological mechanisms, how to use needles, the concept of royalty.
The answer is B, immunological mechanisms. So he developed smallpox vaccine, but it was not still very clear to them at the time how these things worked. Okay, so let's move on. Ignaz Semmelweis observed that what practice could prevent disease transmission in maternity wards?
Hand washing.
Hand washing, correct. Germ theory provided the theoretical framework for developing what?
Vaccines against specific pathogens.
Yes, correct. I'm hearing only two people's voices. So how about the rest now? Those of us typing, we can still unmute and let's talk. Okay. Let's just do a little more together. It's always better to do things together. We go soon close. The 20th century witnessed a drastic reduction in mortality from what?
Infectious diseases.
Yes, from infectious diseases. You know, they had a lot of plagues, bubonic plagues, cholera, all those infectious diseases. But within the 20th century, they had science that started making headway, and people knew, okay, let's live, let's be neat, let's be clean. And then there were vaccines and what's it called now? And antibiotics. Okay. Alexander Fleming was credited with the discovery of which antibiotic in 1928? Somebody was saying penicillin earlier. Is here Alexander? Yes, he's the one that discovered. He was the one that discovered penicillin. Okay. The development of streptomycin in 1940s provided the first effective treatment for what? What did they use it to treat?
Cholera.
Now,
Development of streptomycin.
TB, tuberculosis.
Tuberculosis.
The antibiotic era brought a new challenge known as what? So let's look at the options and answer. I hope the rest of us are following, even those that are not talking. Yes, the antibiotic era brought a new challenge known as what?
Antibiotic-resistant bacteria. That's the B.
Antibiotic resistant bacteria. That's correct. Because by the time antibiotics came into play, bacteria, they decided that if people want to kill us, we are going to find a way to survive. So they started becoming resistant. And also because people started abusing antibiotics as well. The epidemiological transition is characterized by the increasing prominence of what? Let me be looking at that box.
Increasing, it was increasing waterborne illnesses. Or is it disease like heart cancer? No. Workplace injuries.
So the epidemiological transition. Initially, many people were dying from infectious diseases. But at a point, they now discovered that if we can keep our environment clean, if we can, we now had antibiotics, that, okay, all of this can help us, preserve life. So there was now a transition from people dying from infectious disease. It now started to become more of chronic diseases. So people started to die from chronic. It now became chronic diseases that became the problem, no longer infectious. It was like, okay, we've conquered infectious diseases. So now it's now chronic diseases that we are facing. Okay?
Okay.
Somebody's hand is raised. Please unmute. We are all free to unmute and talk. You can unmute, talk, and mute yourself again. We can unmute ourselves, so.
Hello.
Yes.
So when the first lady, sorry, I
Hello.
forgot her name. Can you hear me?
Yeah. Good evening.
Okay.
Is
Yes,
this
ma.
Mo?
When you were giving the
Yes, I
lecture,
want to say you muted us. Thank God you unmuted us
Oh,
now. Thank you.
sorry. So sorry. So sorry. It was because I was hearing some people's voices. I thought everybody was unmuted. Sorry. Sorry. Okay, so we can participate now. Oh, yeah, let's move on. Okay.
so I was saying,
76.
We're in question 76, yes. The Framingham Heart Study, which began in 1948, established the concept of what?
Modifiable risk factors for cardiovascular diseases.
Correct.
Becoming that now.
So that is it becoming down? That
I
Framingham
know you
study.
understand now.
Yeah, let me explain. The Framingham Heart
Yeah.
Study was a cohort study. So cohort studies are studies where you follow the participants to identify incident cases, like Dr. Bello taught us. So this Framingham study, it has been going on for a long time. And what they do is they are using it to identify the risk factors for cardiovascular diseases. Okay. So it's been ongoing since 1948. In the 1964 Surgeon General's report provided definitive evidence linking what to what?
Cigarette smoking to lung cancer.
Cigarette smoking to
Cigarette
lung
smoking to
cancer.
lung cancer.
Correct.
Mm.
Okay. I think there were two surgeons. I can't remember their name now. Is it Bill and Bud or what? Now I can't remember them now. Okay, so cancer control approaches encompass prevention, early detection, and what?
Your lifestyle factors.
You said they should ignore lifestyle factors. Look at the option well, though.
The question is saying that we should control approaches.
Surgical removal.
So support, survivorship support.
Survivorship support.
Survivorship support.
Survivorship
Returning
B.
support.
is survivorship
Survivorship
support.
support, correct. Vaccination campaigns in the 20th century became key tools in what?
Increasing
Disease prevention and saving
Disease
millions of
prevention.
lives.
Saving
makes
millions
million.
of lives.
Correct. Disease prevention and saving lives. Okay, we're stopping in 3 minutes. Before antibiotics, tuberculosis patients were often managed primarily through what?
Isolationist and intolerant
Isolation is
Isolation.
pressure.
Correct.
What?
The WHO was established in when?
1948.
Correct.
Nice.
Yes, so Sabi. The WHO's constitution states that health is what?
Wealth.
Complete states of physical,
No,
mental, and
statement
social
complete
well-being.
physical, mental,
This
and
is the
social
long
well-being. That's
environmental
holistic
and
something
social
like that.
well-being.
B.
Correct.
B.
Correct. Complete state of physical mental well-being. Which disease was officially declared eradicated by the WHO in 1980?
The
Polio.
disease officially declared what? Eradicated by WHO.
It should be
Polio.
smallpox. Polio.
Was it
Polio.
polio or smallpox?
That's
Smallpox.
polio.
Was it polio or
Small.
smallpox?
It was
Smallpox.
Smallpox.
Smallpox. The WHO.
Smallpox.
Okay, yeah, correct. Please, in case my
I
this
think
thing
which
goes
one is
off, just know it's my
Break.
network. Oh, that's good night. If my whatever goes off, it's my network. Okay, 2 minutes more. Let's go. The WHO coordinates international health work through how many regional offices?
I don't know this one. It's a guesswork this time.
I think
Somebody
it's
should
6
help.
regional offices. So we need to
Six across the nation.
we need to check it. There's
6.
AMRO, there's the I think Pan American, there's the Africa regional office. So we'll go and check it
Then
out.
there is
One on each continent, and then headquarters in New York.
So
New York.
Sorry, wherever their headquarters
we
is,
don't
they
have
have
any
a,
headquarters in New
they
York.
have.
Headquarters in France.
Thank you.
in
Headquarters
France.
how many is it in
Geneva.
total?
Let's go and
It's
check.
the UN that has headquarters in New York. I think I can't remember where WHO is, but it's the UN that has headquarters in New York.
Okay. Make we check out. The Centers for Disease Control and Prevention was established in 1946 and originally focused on what?
Malaria control.
We are sure, Abby, because me, I don't know.
No, it's not malaria control.
Okay,
No,
I thought
Are you sure? I think it's mental health though, because
it
it
looks
was
like
after the
mental
World
health
War.
to me.
It was
It
after
can't
the
be mental
World War.
health.
Okay, we'll go and check sharp. But from my reason, after the World War, there were lots of soldiers that had mental issues. PTSD was very terrible. You see people turning on their own people because any small sound triggers them. So for my thinking, I haven't read that part. So that's just my opinion. Everybody can check, please.
It's mental
Thank
health,
you.
please.
Thank you
Hey,
very
there's a
much.
guy is saying mental health.
Okay,
I might trust that one.
last question. The
Ebola.
CDC's investigation of which 1976 outbreak demonstrated the value of systematic epidemiological
The
investigation.
Black Death.
Black Death,
Black
Black
Death.
Death,
Hey,
the Black Death.
Black Death.
Masu Sabi Buko, God abeg.
Black Death, death that is black.
Okay, so this is the end for today. Thank you everybody for coming.
There's a
Thank
lot
you so
to.
much.
Thank
Okay.
you,
Thank
Emma. God
you.
bless you for this.
And our anchor,
Please,
Chiamaka.
can we have these questions that is just aligned there? Please, I'm
No,
begging
no,
you.
we will not have it. We will not have it.
Please
I
now,
need
why
the
you doing?
question.
Please
Please, we will not have
now.
it.
Why are
Let's
you
just
saying
continue
please as if I
tomorrow.
will not send it? Good night, everybody.
Thank you. Good night.
Good night.
Thank
So
you
Good
very
let's
much,
sleep
night.
well.
Dr. T.
See you
Good
all
night.
Good night,
tomorrow.
ma'am. Thank you. Good night,
Thank you
everyone.
so much. Good
Yeah, good
night. God
night.
Thank you.
bless you.
My battery is
Good
finished.
night. Thank
Good
you.
night.
Nice weekend, guys. Bye.